Practical Pharmacokinetics, Part 3, Drug Level Analysis. It's quiz time! Well, not really a quiz, but a series of practice problems to test your skill in calculating vancomycin and tobramycin doses using kinetics. I'll first present the three cases, then I'll give you time to solve the problem. I'll then go over each case and provide the answers. Here we go with the cases. LM is a 32-year-old female with a history of myelodysplastic disorder, recently transferred from another hospital. She now develops fever and shortness of breath. She's concurrently on IV levaquin and IV fluconazole. Her height is 5 foot 9 inches, weight of 60 kilograms, and serum creatinine of 0.6. Cultures have been negative. The MD orders vancomycin per pharmacy. You may stop or pause the video at this point to solve this case. A 50-year-old male is admitted for knee surgery after a motorcycle accident. The patient has a penicillin allergy. He gets hives. Postoperatively, the patient is to get surgical prophylaxis with vancomycin for 24 hours. The pharmacy is asked to calculate the dose. He is 6 foot 2 inches, 70 kilograms, with a serum creatinine of 1.4. Can we use a cephalosporin instead of vancomycin? You may stop or pause the video at this point to solve this case. JH is a 45-year-old female admitted from a board and care facility with fever and confusion. The patient has a history of seizure disorder and past multiple episodes of pseudomonal UTIs. Her urine analysis is cloudy and shows many bacteria. Her temperature is 101.2 and blood pressure is low. Her height is 5 foot 3 inches, weight of 70 kilograms, serum creatinine of 0.8. The emergency room doctor suspects sepsis and orders vancomycin 1 gram times 1 and pharmacy to dose tobramycin. You may stop or pause the video at this point to solve this case. We round the serum creatinine from 0.6 to 0.8 and we use actual body weight. We multiply the creatinine clearance by 0.85 since she's a female. The creatinine clearance comes out to 95.6 mLs per minute. Her VD is 42 liters. The Vanco factor we use is 1 because the serum creatinine is less than 1 and she is younger than 70 years old. The vancomycin clearance is equal to 5.74. The KEL is 0.1366 with a half-life of 5 hours. We will use a tau of 8 hours because she is not that sick to use a 6-hour dosing interval. The estimated dose calculates out to 781 milligrams, so we'll round the dose up to 1,000 milligrams and give every 8 hours. We need to use the long equation since the half-life is less than 6 hours. Once we plug in the necessary parameters, we get a C peak of 33.5 and a C trough of 12.9. The loading dose calculates out to 1,250 milligrams to give a level of about 30. Practice problem number 2. The serum creatinine is 1.4 and the creatinine clearance calculates out to 62.5 mLs per minute. The VD is 49 liters. The Vanco factor is 0.8 because the patient's serum creatinine is above 1 and the age is younger than 70 years old. The Vanco clearance calculates out to 3.0. The KEL is 0.06 with a half-life of 11.3 hours. The dosing interval is 12 hours. The estimated dose is 713 milligrams, which will round up to 750 milligrams, and so the dose will come out to 750 milligrams every 12 hours for 2 doses, with a peak level of 29.4 and a trough level of 14.4. There's no need for a loading dose here because it's just for surgical prophylaxis. Now, can we use a cephalosporin instead of vancomycin? Probably not in this case, since this patient has developed hives, which has the potential to close the airway if it is severe. So play it on the safe side and prescribe vancomycin instead of a cephalosporin. The patient has an ideal body weight of 52 kilos, with an actual body weight of 70 kilos, so we use the ideal body weight in the creatinine clearance calculation. We multiply the creatinine clearance by 0.85 since she's female, and it comes out to be 73 mLs per minute. The VD is 15.4 liters, and the tobramycin clearance is 4.37. The KEL is 0.2837 with a half-life of 2.4 hours. Therefore, the dosing interval, or tau, will be 8 hours. The dose, estimated dose, calculates out to be 97 milligrams, and we need to use a long equation since the half-life of tobramycin is less than 3 hours. The dose of 100 milligrams every 8 hours will give a peak level of 6.75 and a trough level of 0.8. The trough level is less than 1, so that's good to prevent nephrotoxicity. A loading dose of 110 milligrams will give us a level of 7.14. The dose is very close to the regular maintenance dose of 100 milligrams. Let's move on and talk about when we should draw drug levels. Let's first talk about aminoglycosides. Aminoglycoside doses are infused over 30 minutes. This is followed by a 30-minute alpha distribution phase before the drug undergoes beta elimination. The trough is drawn prior to the dose, and the peak level is drawn 30 minutes after the end of the infusion, after alpha distribution is complete. For vancomycin, doses are infused over 1 hour, and then this is followed by a 1-hour alpha distribution phase before the drug undergoes beta elimination. The trough is drawn prior to the dose, and the peak level is drawn 1 to 2 hours after the end of the infusion to allow for alpha distribution. Alternatively, troughs have also been scheduled after the peak level within the dosing interval instead of prior to the dose. Make sure drug levels are drawn at steady state. This is most important to accurately calculate the VD off of actual levels. And why is steady state so important? We know because if we draw the levels too early, it's going to give us inaccurate results. You got drug levels. Now what do you do with them? The first step is to calculate the KEL. Here's an example of aminoglycoside peak and trough levels that we want to analyze. In order to calculate the KEL, we just move the trough over to the next dosing interval. We know that we can do that because we're at steady state. Then we simply use the degradation equation above and solve for KEL. Remember that the time is the dosage interval tau minus 1 hour. 1 hour represents the 30-minute infusion and 30-minute distribution. We can use the following equation to help us complete the mathematical equation. Similarly for vancomycin, when we have a peak and trough level that we want to evaluate, we just move the trough over to the next dosing interval. Again, we know we can do this because we're at steady state. And then we simply use the degradation equation above and solve for the KEL. The only difference is that the T in this case is the dosage interval tau minus 2 hours. The 2 hours represents the time of 1 hour infusion and 1 hour of distribution. Again, we can use the following equation to help us solve mathematically the solution. The next step is to extrapolate back. Well, what does this mean, extrapolate back? Well, it's to try to find where's the true peak level. When does the true peak level occur? This is a controversial issue. Some say the true peak level occurs at the beginning of drug infusion. Other people think it occurs at the end of drug infusion or before alpha distribution. And still others say it's the measured peak value. Of note, we shall proceed by assuming the true peak occurs at the end of drug infusion. Wherever you define the true peak level, you will need to take the measured peak level and extrapolate back by a certain time to get the true peak level. When do I need to extrapolate? Do I need to do this all the time when I get levels? In some circumstances, extrapolating will not make too much of a difference between the measured and the true peak, while other times it will be significant. It all depends on the slope of the elimination, the KEL or half-life. For now, let's always extrapolate. Here are aminoglycoside peak and trough levels. We take the peak level and extrapolate it back to get the true peak level, which occurs at the end of a 30-minute infusion. We use the following equation to solve for the extrapolated peak. CT is the measured peak, K is what we solved in the previous slide, and T is the time between the measured peak and the extrapolated peak, which is 0.5 hours. The same applies for vancomycin peak and trough levels. We extrapolate the measured peak back by 1 hour to get the true peak level, which occurs 1 hour after the end of the infusion. We solve for the extrapolated peak by using the degradation equation, where CT is the measured peak, K is what we solved in the previous slide, and T represents 1 hour distribution. The third step is to calculate the vomit distribution based on the drug levels. We've seen this slide before, where a drug is administered to a patient. A single dose starting from 0 is distributed into a volume of VD and achieves a certain blood concentration Cp. This is exemplified by the fundamental kinetic equation Cp equals dose over Vd, which when rearranged shows up as Vd equals dose over Cp. Here's an example of multiple doses of a drug administered to a patient. C peak, or the measured peak, is achieved after a 30-minute infusion and a 30-minute distribution period. The measured peak is extrapolated back 30 minutes to find the true peak. We can then use the previous fundamental equation and rearrange it to solve for the Vd, which would be equal to the dose divided by the C peak extrapolated minus the C trough. So we take the dose and we divide it by the extrapolated peak minus the C trough. Here are the tobramycin peak and trough level results. The patient is on tobramycin 100 milligrams every 12 hours. Tobar levels drawn around the third dose are as follows. The tobramycin trough level drawn at 0.555 is equal to 1.6 micrograms per mil. Tobramycin is infused from 0.600 to 0.630, and then a tobramycin peak level was drawn at 0.720, which is 20 minutes late. That value was 5.7 micrograms per mil. Calculate the kinetic parameters and determine what the new tobramycin dose should be. When starting out, it's always a good idea to make a drawing of the drug levels and times on a graph, as in the diagram shown. The first step is to solve for KEL. We move the trough level over to the next dosing interval, as we're allowed to do this at steady state. We then use the degradation equation to solve for K. Ct is the concentration of 1.6, which is the trough. C naught is the initial concentration, which is the peak level of 5.7. T is the time between the two levels, which is the dosing interval of 12 hours minus the 1 hour, which accounts for the infusion and distribution, and 0.33 hours to account for the drug level being drawn late. After calculations, the KEL comes out to be 0.119 with a half-life of 5.8 hours and a selected tau of 24 hours, which is taking into account of using the post-antibiotic effect. The second step is to extrapolate the measured peak level. And again, we use the fundamental equation or degradation equation to solve for C naught, which is the extrapolated peak. Again, the time difference is 0.83, which is 30 minutes allowed for distribution, plus additional 0.33 hours to account for the delay in the peak level drawn. The extrapolated peak comes out to be 6.3. The third step is then to solve for Vd. which is equal to the dose divided by the difference between the peak and trough levels, which would be 100 over the difference between 6.3 and 1.6, which is 21.2 liters. We now have all of our kinetic values, and so we solve for a new dose, which would be 7 times the VD of 21.2 times 1 minus e to the minus k, which was 0.119, and the dosing interval we decided on was 24 hours. The dose becomes 140 milligrams. We then recalculate a new peak and trough based on the dosage of 140 milligrams every 24 hours, and we get a peak level of 7 and a trough level of 0.4. So this will be our new dosage. Vancomycin, single trough levels. How good is doing a single trough level for vancomycin? If we can draw peak and trough aminoglycoside levels, why couldn't we draw peak and trough vancomycin levels? The reason was that no one really knew when the peak vancomycin level occurred. So because of that, no one drew vancomycin peak levels, and we ended up just drawing only trough levels for many years. In fact, an excerpt from the ASHP IDSA vancomycin consensus review in January of 2009 stated, available evidence does not support monitoring peak serum vancomycin concentrations to decrease the frequency of nephrotoxicity. So for many years we drew only vancomycin trough levels, which we knew was inadequate. We wanted vanco-trough levels to serve as a surrogate marker to predict vancomycin's AUC, or area under the curve. Unfortunately, studies have shown that trough levels have been imprecise in predicting the AUC. Nevertheless, the trough level is a convenient method that we are using for now. However, big changes are coming, as will be explained in Part 4. In the meantime, let's take a look at an example of following up on a single vancomycin trough level. Patient JM is on vancomycin 500 milligrams every 12 hours. His actual body weight is 80 kilograms. The vancomycin trough level drawn prior to the fourth dose is 16 micrograms per mil. What should the new vancomycin dose be adjusted to? The goal trough is 12 to 15 micrograms per mil. Here are the steps to calculate the vancomycin parameters from the trough level that we just drew on this patient. We set the VD at 0.7 liter per kilogram, and then we use a revised KEL equation, which is a combination of many fundamental kinetic equations that are reassembled into one. We calculate the half-life and select an appropriate dosing interval, and then we calculate a revised clearance, KEL times the VD. We then calculate a new dose to achieve the new target trough of 12 to 15, and we insert that value into the C trough in the following equation. We then recheck the new C peak and trough level to make sure that they are therapeutic. So for this particular patient, the VD is 56 liters. We then calculate a revised KEL using the dose of 500 milligrams every 12 hours and a measured trough of 16, and come up with 0.037. The half-life is 19 hours, and we select an appropriate tau of 24 hours. The clearance is calculated out to 2.07. We then need to calculate a new dose to achieve the new target trough of 12. We insert the target trough of 12 into the following equation, and we get 962 milligrams, which we then round up to 1,000 milligrams and give that every 24 hours. We then recheck the new peak level, which becomes 30.3, and the new trough of 12.5. Let's summarize what we learned in this installment. We solved 3 kinetic dosing case problems for vancomycin and tobramycin and reviewed the answers. We described the timing of when aminoglycoside and vancomycin drug levels should be drawn. We discussed the issue of when and where the true peak occurs and expressed the importance of extrapolation. And we explained the method of analyzing patient-specific peak and trough only drug levels to solve for a new dosage. In part 4 of this series on practical pharmacokinetics, we will learn about the impact of pharmacodynamics on dosing vancomycin and aminoglycosides. We will compare the current methods of trough-only dosing with newer Bayesian and trapezoidal methods for calculating vancomycin doses. So stay tuned. Thanks for tuning in to watch this installment of the PharmEasy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below, or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.